always know I'm going to learn a lot. And I see that the stream is live. So we are live, Rolandos. Hello and welcome, everybody. It is wonderful, wonderful to see you all, or not see you all, but know you're there again. And let me, before I introduce Rolandos, who is amazing, and he's going to be sharing all his amazing knowledge with us today, I want you all to think about this for a minute. What if everything that you thought you knew about cholesterol and heart disease was wrong? Because today we're talking to Dr. Rolandos Pavlou, who is here to challenge decades of medical dogma on LDL cholesterol, on statins, on cholesterol, on what really causes cardiovascular disease. So trust me, you're really, really, really going to want to hear this one, okay? So hello and welcome from me. I'm Tamsin Murphy, registered dietitian and head of content here at Nutrition Network. And we are joined today by Dr. Rolandos Pavlou, who is a general practitioner and a Nutrition Network certified practitioner as well. And he is one of our featured expert lecturers on our brand new cardiovascular health training, which is launching in just, is it now 2 weeks, a week and a half from now, on the 27th of August, where he gives 3 amazing lectures. One on the history of the diet lipid heart hypothesis, one on cholesterol and LDL cholesterol, and then one on statins. So he's going to speak to us a little bit about those topics today as well, so you can get just a little sneak peek into those topics. Rolandos, thank you so much for coming here, challenging our beliefs, shaking things up a little, and joining us with all your expertise.
Thank you. I'm very excited to be with you, sharing all my research on these topics. Of course, I'm standing on the shoulders of Nutrition Network research and international writers and scientists who have collected a huge database on these topics. Actually, I really wonder how these theories like the lipid heart hypothesis still stand, can still survive all this data, which is refuting it.
Yeah, absolutely. Well, you're going to tell us how, hopefully, now during this interview, and even more in depth in the cardiovascular training. And I do want to tell anyone, if you want to sign up for the cardiovascular training, the heart health training, now is your chance, because if you sign up before the launch date, which is the 27th of August, you can get 30% off, an early bird discount. And for anyone in the therapeutic carbohydrate restriction space, and to be honest, anyone, anywhere who cares about their heart, we all have one, you should be taking this training. So Dr. Pavlou, can we start off by, firstly, I did actually realize that you've written a book on this topic. Is that correct as well?
Yes.
Wow. So
unfortunately, it's in Greek.
Oh, you need to get it translated so the likes of us who can't speak Greek can understand it.
Maybe.
That would be great. So Rolandos, you challenge one of the longest standing medical beliefs in your lectures in the cardiovascular health training by Nutrition Network. And one of the longest standing medical beliefs that I'm talking about is that cholesterol is the main cause of heart disease. Can you tell us what made you question this truth?
Well, the trigger was my father's heart episode he had after taking statins for 7 years. And that started me thinking, how could that happen? That was supposed to be avoided by statins. So I started researching cholesterol and everything around the cholesterol myth. And that's how I found the Noakes Foundation and all the research that has been done there. And that's how I ended up with the book, because I felt that this is so groundbreaking, so important for people to know what's the truth about cholesterol, that I couldn't resist trying to get it together and publish it as a book. That was the trigger. Now, how can that rudimentary, so crude theory still survive? I really wonder. because it started off in 1858 with Virchow's discovery of some lipid compound inside the vessels. So he proposed we should call this cholesterol, and then it changed into cholesterol. And he was very cautious about it, saying that, however, I observed that these kind of lesions are the result of inflammation, and they appear where inflammation exists. So he was more cautious than contemporary scientists, modern scientists. And in spite of all the accumulating data, it still survives the crude idea of the plumbing model, like the pipelines of our sink clogging with fat if you throw too much fat in the sink, which is ridiculous. Otherwise, we will be accumulating meat inside our vessels, etc., if we eat too much meat, or grains if we eat too much grain. So it is not like that, and we must understand how complicated the nutrition, the metabolism of cholesterol, and what actually blocks the vessels. It's much more complicated than they initially thought.
So maybe you can take us from there, because it sounds like, okay, well, there's this cholesterol in the blood vessels, but there's also inflammation in those blood vessels. How did it grow from that into being cholesterol is the problem, cholesterol causes heart disease, which unfortunately is still where many of our clinicians sit right now, thinking that that is the case? How did we get to this point where that is the status quo, that is the truth?
Well, the 20th century was the period of a great increase in cardiovascular disease and deaths. And this was the trigger. All people around the world were worried about this new pandemic. And the natural thing to do would be to try to investigate the new factors that came into our lifestyle and try to pinpoint the exact causes among them. And the new things that would naturally be underlined, would be investigated, would be smoking, the seed oils, and the immense increase in sugar consumption. These three factors were totally ignored, although there were honest scientists like Yatkin or Goffman or Ahrens or Allbrings, who tried to show that it was not cholesterol that was responsible for the increase, but then it was Ansel Keys who led the campaign against cholesterol and spearheaded the campaign to lower cholesterol and reduce dietary fat, saturated fat, and cholesterol, which culminated in the dietary guidelines in 1980. But I'm not a fan of this personalized theory that Ansel Keys was the reason we had this campaign. Behind him were larger forces like the sugar industry, seed oil industry, that had huge interests, financial interests. So it has been proven since 2016 that scientists from Harvard were funded to come up with some data, some studies that were not real, to shift the focus on cholesterol so that they would divert attention from sugar and seed oils concerning the increase in cardiovascular disease. This idea, it was so confused. One is cholesterol, dietary cholesterol may influence cholesterol in the blood, which if it increases, then we would have cardiovascular disease. Second, the saturated fat or total fat would mean an increase in LDL, and that would lead to heart disease. And so it was a multi-phased campaign with no concrete data, no evidence supporting it, and the limits set first by Ansel Keys and then by the dietary guidelines were not science-based, and the committee that was responsible to draft the guidelines said that we have no time to wait for the evidence, the scientific evidence we need to back up our guidelines. So they published it, they launched it without any data, and it still is valid until today. Now it is being challenged by the new government. Maybe we have some changes now. The latest news a month ago is maybe we have a change of mindset around the saturated fat, dietary saturated fat. I don't know. We will see.
We can hope. So, I think you paint this picture so beautifully. And for any of you, our listeners out there, who want to go and check up on what Rolandos is saying, I highly recommend, other than obviously doing our training and the lectures, but I highly recommend reading Nina Teicholz's Big Fat Surprise. She is an exceptional investigative journalist who puts together all the evidence and the historical findings of these committees that were behind this, that were meddling in what the dietary guidelines say. She puts all the evidence on the table there, and she is absolutely amazing. So please go and read her book to learn all about this history that Dr. Pavlou knows so well and has just given to us in a nutshell. Another person I would like to direct you all towards is Zoe Harcomb's book. Her books, but also her, if you go onto Google Scholar and you look up her research around dietary guidelines, that's Zoe Harcombe, Harcombe. Look up her research. She did her whole PhD thesis on reanalyzing whether there was evidence to support the dietary guidelines that went out in the early 80s. And as Dr. Pavlou has just told us very clearly, the evidence was not there to support that. So please go and look at that, just so that you can assure yourself that what Dr. Pavlou is definitely saying is evidence-based. But then you say there wasn't any research. What about, you said it wasn't just Ansel Keys. Fair enough. It took a lot more than one man to set all of this in motion. But what about his hallmark 7-country study, which showed that the people in countries who ate lots of saturated fat had high cholesterol and ended up dying of heart disease? How is that not evidence? Tell us about that, Dr. Pavlou.
It is a very interesting topic because Greece was the featured country, and Ansel Keys loved the Cretans. That was his model. So I paid special attention to that. But it was heavily flawed. First of all, it is an epidemiological study that cannot be relied on as concrete evidence, as concrete proof. It can only be an associative, maybe indication that must be confirmed with further RCTs and meta-analysis, so that we have more concrete evidence and not just observing populations. Anyway, there were many consistencies in those data. First of all, he only observed 34 Cretans he visited the island during the Christian Lent, Orthodox Lent, which excludes meat from diet. So it is really flawed. And then we have inconsistencies among countries. He tried to avoid countries that did not comply with his theory, like excluding Switzerland or France. And also Japan had the opposite effect, with very low cholesterol levels and very high CVD. So it was not really objective. He did not fairly include all populations, and that was pointed by Yerushalmi and Hilbo right after he presented his first data in Mount Sinai, his 6 countries plot graph he created. They showed that he cherry-picked 7 out of 22 countries that actually showed no association of cholesterol and or other calories coming from fat with cardiovascular disease. So it was really a very, very bad quality, low quality of data. Then came the Framingham, which is still used as reference for current guidelines, which showed the opposite result from what they expected. And George Mann was given to quit and change his research because he had direct instructions not to publish the results because they were not what they expected. So still, Framingham was not what they wanted it to be, and it should be really mentioned as proof against the theory or the lipid heart hypothesis.
Wow, it's crazy because I think most people feel like science is this objective space, right? That's not contaminated by all of the human failings. But we can clearly see that that is not so. We are having industry meddling in scientific studies, funding certain studies, then stopping the publication of certain studies or certain results due to them not fitting their hypotheses. I mean, that's the essence of bad science. If cherry picking data in the 7-country study wasn't bad enough, imagine you take almost 40 countries and you're like, no, you don't adhere to my hypothesis. No, we're excluding you because you also don't. And then you only include 6 or 7 countries because the rest didn't suit you. I mean, that is terrible. That is terrible, terrible, terrible. Also, I do want to mention, Dr. Pavlou, the Minnesota coronary experiment, which was a whole lot of data was hidden in someone's basement. Is that correct? And then was pulled out and reanalyzed only in 2016. Do you remember the story behind that one?
Yes, of course. They initially studied these, organized this study during 68 and 73. They had one group with high saturated fat intake, and the other group had the saturated fat, half of it replaced with seed oils and margarine, and they showed that a reduction of 31 milligrams in serum cholesterol resulted from that study. So they heralded it as great news that it proved their point, but total mortality increased. So they didn't like the results. They hid it in the basement, the chief researcher. And then in 2016, Christopher Ramsden reevaluated the results and found out that for every 30 milligrams reduction of serum cholesterol, there was a 22% increase in all-cause mortality. And among elderly people older than 65, the increase was 35%. So it was the exact opposite of what they expected. But it is a theme in many studies following that once a drug or dietary means can lower cholesterol, that's good enough. We don't need to associate that with mortality, with CVD, cardiovascular events, and so on. And many studies publications start with the claim that it is well established that high cholesterol is associated with high cardiovascular events, and they start their own ideas from that point on. They take it for granted now. That's what statins did as well.
Yeah, that is so sad, because sure, eating less saturated fat and more polyunsaturated fat may lower cholesterol, but if it's more likely to make you die, which is what the study found, then why on earth would you want lower cholesterol, right? And I mean, the Women's Health Initiative, which I know you go into more detail about, it also found that women who had cholesterol higher than 5, which is considered in other words, high cholesterol, they were more, especially most postmenopausal, they were more likely to live a long, healthy life. I mean, we're seeing this again and again and again. It's crazy that doctors are still treating cholesterol with statins, and we will get into that. It's crazy. It's absolutely crazy. All right, but I just wanted, before we move on, because we have so much to rack, as you can see, Dr. Pavlou's amazing encyclopedic knowledge about this topic. But before we go on, I just want to acknowledge our wonderful audience out there. Sean, it's really good to see you. Hi, thanks for joining us. And Kieran, also, you join every single live. We love you so much. Thank you. Thank you so much for joining. And we're really glad you're enjoying the discussion. And Kieran says that so many of us have witnessed our parents and grandparents diligently taking their statins, only to succumb to cardiovascular disease, which is exactly your story, Dr. Pavlou, as well. And this needs to stop, because these are real people. These are not numbers. Cardiovascular disease is the biggest killer of populations worldwide. And that sounds like, okay, it's a really big stat. But every single one of those people are people's mothers, fathers, brothers, sisters, aunties, uncles, children, friends.
And this is a very, very important point, because modern doctors are treating one isolated number. When we guide people into a ketogenic diet, we see improvement in all, in a great spectrum of markers, and we only see an increase in cholesterol total and LDL, which is not the dangerous kind of LDL. And yet, these people ignore all other markers. They focus on this one, and against all logic, they think that this isolated factor can cause an increase in risk, although we have an increase in HDL, a decrease in CRP, a decrease in HbA1c, etc. It's ridiculous. They treat one isolated number, no people.
Yes, which isn't even sure that it's a real risk factor, and I just want to refer back to those of you who didn't listen to Dr. Budov's interview last week, where he says treating cholesterol with statins is the same logic as treating someone who falls into a high risk category for cancer, like someone who smokes, with chemotherapy. You don't treat a risk factor, which might not even be a risk factor in the case of cholesterol. You treat an actual condition. So you test for atherosclerosis, and then you treat atherosclerosis. You don't treat a marker. But let's talk about this cholesterol, Dr. Pavlou. LDL cholesterol. This is the demon, the villain of our story. For the last few decades, everyone has said, your bad cholesterol, your LDL cholesterol, that's the bad one. That's the one that causes you to have plaque, or so-called atherosclerosis in your blood vessels, which causes you to have a heart attack.
Well,
What is
let's
really
challenge
happening?
that.
Let's
Let's
challenge it.
challenge that because, for example, let me give an example. If you're diabetic, you probably have a tenfold risk for cardiovascular disease. What happens then? Your plaque will increase. So you didn't eat more cholesterol. You didn't eat more saturated fat. Your serum LDL levels may even have decreased because, for sure, your doctor will tell you take statins to reduce the cardiovascular risk. Aiming for the wrong factor, you're diabetic, and instead of trying to correct your glucose and all the other factors coming with it, the transaminases, the triglycerides, the low HDL, they don't care about that. They only care about LDL. So how come a diabetic build the plaque without an increase, without a high serum level of cholesterol? And why does someone who goes on a long-term fast, like a week, will experience a 37% of LDL levels and a 66% of increase of total cholesterol levels? How did that come? Why did LDL increase? It was not dietary, it was fasting, which means that the body, because of autophagy, needs more cholesterol to build and renew the cells that undergo autophagy. So it is nature so wrong to create such harmful mechanisms? Are we so clever to correct nature? And now the levels of the goals for cholesterol and LDL are impossible to reach without drugs. It is important to understand that we have entered an era of drug-dominated cholesterol control. In previous years, before the statins, they would say, okay, you have to reduce saturated fat, you have to take in more seed oils, etc. But now their limits are way beyond that. You cannot reach it. The European Society of Cardiology has come to the point of saying the lower the better, LDL, starting from 35 milligrams per DL, which is really ridiculous. It's killing you. You will
So
have
why is it
a
killing us,
variety
Dr.
of
Pavlou?
side effects.
Tell us about those side effects. Why do we need cholesterol? Why is lower cholesterol not better?
Well, every cell needs cholesterol for its proper membrane function. And this means that a number of functions at cellular level cannot work well if there is lack of cholesterol. Even a small decrease in cholesterol, for example, 10% decrease of cholesterol will damage the ability of the pancreas beta cells to secrete insulin because it's through exocytosis that it's released. The ion exchange at membrane levels is compromised, and this means neurological and heart problems. And the most common side effect of statins is the impairment of muscle function and neurological nerve cell function. Both these suffer both because of lower cholesterol and because of lack of CoQ10. which is also produced by the same mevalonate pathway that cholesterol is produced. So they cut this pathway, stopping the production of many different proteins and affecting all functions in the body. It is so essential, so deep inside our body that there is no cell that is not affected by this change. The hormones, all estrogens, testosterone, cortisol, vitamin D, everything that is sterol is produced by cholesterol. The immune system cannot function well with low LDL and low total cholesterol. Cancer is more common among people who take statins, who lower their cholesterol, because the antioxidant mechanisms are compromised, both through CoQ10 reduction, but also through cholesterol reduction. And it is very interesting that all pharmas, all the industry publications on statins, they claim that side effects are off-target effects. And this is a misnomination, because actually it is cholesterol lowering that is the major factor for these side effects.
Wow. Well, that is a compelling case, because basically you're saying by inhibiting the production of cholesterol, you're also inhibiting the production of coenzyme Q10, which is essential to muscle function, which is why you get that angina or heart pain and other muscle pains when you take statin medication, which lowers cholesterol. You get a reduction in all those hormones, right, that you mentioned that have cholesterol as their basic structure, all those steroid hormones. And I know I spoke to Dr. Manjunath Markandeya, who's a neurologist and a critical care neurocritical surgeon, yesterday, and he was telling me about a patient that he had who had Guillain-Barré syndrome, and how the cholesterol, trying to reduce the cholesterol that was also happening at the same time, was impairing his ability to remyelinate his neurons. And when his cholesterol levels were allowed to go up and encouraged with healthy fats and with everything else, the proper nutrition, he actually ended up recovering from a condition that was thought would never be able to recover. And then I also want to mention those side effects of statins, and we'll get into statins. I feel like we've gone towards statins already, but when I was reading the package inserts for statins, when I was looking into cholesterol at one stage, I basically saw the side effects being dementia. It was dementia. It said, if you get any of these signs or symptoms, and they listed signs and symptoms of dementia, well, then, you may want to reduce your dose or go off it. And another one is type 2 diabetes. And I didn't think about how that was happening. But now that you've mentioned the role of cholesterol within the pancreas, that makes sense as well, doesn't it?
Well, in the Jupiter study, which resulted in the approval of Cresto, they changed their criteria, and they also included people with high CRP. And that was a better, more effective trial with better results, because all previous studies had been focusing on cholesterol levels, and they, in spite of a decrease, maybe 35% of LDL, they couldn't manage to bring it down, the risk. And in many cases, it was proven that maybe some CV events may be avoided, something like 0.5%, which is very, very, very low. They presented it with relative risk, so that they could make it look bigger. But including the CRP in their criteria, they had a better profile, and they could pick the people who really had higher risk, because the CRP is a much better marker for CV risk compared to cholesterol. And then in the paper, the leaflet inside the crystal package, they now have a warning that it may cause a 2% increase in type 2 diabetes, which is partly because of the mechanism I described. And they come up with a dyslipidemia they cannot handle, they cannot improve. There was no drug that would manage to increase HDL or lower triglycerides, a very, very minor effect by statins. So the main remaining dyslipidemia post-statin use is the main culprit. I mean, they don't touch on the real factors. And it's also very interesting that the LP little a increases by 20% with statin use. It's not only untouched by statins, unaffected by statins, it's also increasing with statins.
So,
and
Dr. Pavlou,
that is probably because the liver is trying to bypass the lack of LDL by upregulating its production of LPA lipoprotein.
Okay, so I'm going to pause you there because I think you've covered so much, and I'm a little bit worried that some of our audience might be left behind a little bit. So firstly, I just want to, now tell me if I'm interpreting what you're saying wrong, but firstly, you're talking about CRP in the Jupiter study. Now, for those of you who don't know, C-reactive protein or CRP is a marker of inflammation, which interestingly is tying back to your point, Dr. Pavlou, back in, was it the 1800s? You mentioned the first guy who noticed that there was high cholesterol, but there was also inflammation. It looks like we're going there again here, right? Yes. So what Dr. Pavlou was saying here is that the Jupiter study showed that there was an improvement, a slight improvement, just like a 0.5% improvement in cardiovascular risk with the Crestor statin. But they didn't just look at the lowering of cholesterol, they looked at the lowering of inflammation by using the marker CRP. And what Dr. Pavlou is saying...
let me correct you. Tamsin, let me correct you. Yes. It was those with a high CRP, whatever the level of cholesterol, had better results than those with a lower CRP, irrelevant, no matter what their cholesterol level was.
So you're saying that the statins were benefiting these people with high CRP due to likely reducing inflammation rather than to any effect they were having on cholesterol.
Exactly.
So I think that's a really, really important effect, because then it's saying, okay, if statins have so many negative side effects, which maybe there are direct effects, but let's call them side effects, then and the reason that they may have some benefit in a very small portion of the population might really be, and seems to very clearly actually be, not the cholesterol lowering effects from what we can see from the study showing that lower cholesterol was associated with higher mortality, right? So if it's not the cholesterol, the lowering effects that they're having the tiny benefit through, then it's more likely that it's through the anti-inflammatory effects from the Jupiter study, right?
Yes, but if we want to look at it with balance, lowering NFKB, which is the exact compound, the inflammatory compound that is also produced through the mevalonate pathway, then we also have a reduction in the immune system ability, capacity. So yes, we reduce inflammation in the vessels, but we also reduce the ability to protect our organism from microbes, and that's why maybe we have herpes or other infections more common among statin users.
Yeah, and I've definitely seen studies, and I've gone blank on the author's name. You might remember, Dr. Pavlou, but I've seen studies looking at cholesterol and immune system, and very clearly higher cholesterol is protective from infectious agents, particularly when it comes to respiratory infections, interestingly, which is why in the whole COVID era, we were actually saying that higher cholesterol appeared to be beneficial to prognosis, interestingly. So all these things that cholesterol does is really interesting. But Dr. Pavlou, I know we've already dived a little bit into statins, and I want to dive into them a bit more. But I feel like we haven't addressed one thing, which is kind of many things actually, because the lipoprotein little a also, and I know you go into that in your lecture as well. And I want to tell everyone who does the training, Siobhan Huggins does a lecture exclusively on lipoprotein little a in this training as well. So you're going to get lots of training on that, which I think is really good because no one talks about lipoprotein little a. So that was just a little placeholder. My question I had was, LDL cholesterol or cholesterol is found within the plaques of atherosclerotic blood vessels. So yes, we're saying that cholesterol is all good and low cholesterol is bad, but somehow it's ending up in these plaques. Surely that implicates cholesterol slightly. Talk to us about that.
First of all, one reasonable argument would be that if the planning model was correct and the LDL accumulates on the arterial wall because its concentration is very high in the blood, then we would probably have more plaques in the veins rather than the arteries, because they have a slower flow that would allow precipitation of these extra compounds. It's turbulent flow that really results in higher plaque. And the carotid and the coronary arteries are more susceptible to plaque formation just because they are under stress, mechanical stress, but also because of chemical compounds like the glucose, and then LDL may be oxidized because of high PUFA content, omega-6 content. So a number of factors may come together to trigger inflammation, and then the body needs to stop the damage, the lesion on the vessel, and uses cholesterol as a means of stopping it. Although I think that Malcolm Kendrick's idea on how clots are formed and then gradually form the plaque makes more sense. And as Paul Mason pointed out, the cholesterol found deep inside the plaques is not the kind of cholesterol found in LDL. It is a crystal form of cholesterol. And along with that, inside the plaques, we find remnants of erythrocytes, fibrin, and platelets, which have nothing to do with cholesterol. So most probably the mechanism involves clot formation in the lumen, and then it sticks to the points of lesion on the arterial wall. That's how it's accumulating there.
Wow. So cholesterol sounds like it's actually, as you described it, it's almost a band-aid. If anything, rather than being the villain, it sounds like LDL is actually the superhero, or rather than the arsonist, it is the firefighter. So I think this is really, really interesting. It shows us how we can just jump to these conclusions without sufficient evidence, and we need to really delve deeper. We could be really doing some serious damage to people's health with the wrong information. So
exactly.
I think let's go back to statins, because I feel like we didn't completely, or shall we go back to lipoprotein little a rather? I don't know. Where do you want to go
Whatever
first,
you
Dr.
like.
Pavlou? Okay. Let's finish the whole physiological thing and then move into the drugs a little bit more. So
Yes.
lipoprotein little a, you say that is upregulated when cholesterol is lowered, right?
What is interesting about LPA is that it may prove to be the band-aid we were talking about, because it doesn't differ from LDL. It is actually an LDL particle with an extra lipoprotein. And this extra lipoprotein gives it some special properties that are not there in simple LDL particles. First of all, it imitates plasminogen and increases the clotting ability of the organism. And these, under natural conditions, may prove beneficial, so that you can respond to injury, skin injury. But then, during our time of chronic inflammation, it may prove a disadvantage. What we should advise in these cases, we don't want to lower the ability of our body to respond to inflammation. We don't want to compromise our healing ability. We want to exclude the causes of inflammation. And that takes me back to the statin question, because if I have a patient that has really high risks for cardiovascular disease and inflammation, then the question arises, should I prescribe statins along with a ketogenic diet, or is ketogenic diet sufficient to counter and reduce this risk? I would say that if this patient refuses to go on a ketogenic diet and exercise and use all our tools we have, then maybe some statin might mitigate, might reduce the risk. But I know from my experience that utilizing statins along with our methods will not allow a full effectiveness of the ketogenic diet. If it compromises the ability of the pancreas to secrete insulin, if it compromises the immune system, how can I work with the diet? It goes against me. So I will choose to guide him with a diet excluding statins. And also, I don't know what the real balance between pros and cons with the statins is, because much of this data was manipulated, was hidden, and I feel that it is not reliable, so that we can have an objective assessment of what the real benefit is. It's marginal based on their claims, but their claims are under question.
Very, very good point, Dr. Pavlou. Now, everybody who's joining us, this is your chance to ask some questions if you have any. I have plenty more questions that I haven't even gotten to, which I'm really bummed about. And maybe I can ask one or two more before we're out of time, but I don't want you guys to miss your chance. So if you do have any questions for this amazing doctor that we have the privilege of having in front of us live to answer your questions, please go ahead, put your questions or your comments in the comment box. We would love to hear from you. I'm watching out for them. In the meanwhile, I just want to ask, because we've got so little time now and there's so many things. So I think let's leave statins, because I think you've made a really, really good point around that. And I think we've all got it. If it's not cholesterol that's to blame for cardiovascular disease and atherosclerosis, what is it? Dr. Pavlou, what is it?
Well, we said it in the beginning, because if we observe the 20th century changes, The major changes were cigarettes and seed oils, and the immense increase in sugar consumption. Of course, that has gone to the next level with the ultra processed food, which we cannot really know what exactly is in it and how these lots of compounds interact to produce new inflammation and increase the inflammation burden. But we ended up, after the dietary guidelines, decreasing, for example, meat consumption experienced a 28% reduction between 65 and 2011, 13% reduction in eggs, 27% reduction in butter, 35% reduction in milk, and on the contrary, a 10% increase in fruit, 17% increase in vegetable, 11% in legumes, and 28% in cereals. So we did what we were told to do. We reduced saturated fat, we reduced meat consumption, and we turned to what they were saying would be healthy. And we have 93% of the American population being characterized as non-healthy metabolically. So if we want to search for the culprits, we need to look at the modern diet, cigarettes, stress, lack of exercise, and all the other factors of modern lifestyle. And the most impressive examples are the Nauru population near New Zealand, a small population that was living naturally on the traditional diet they had. They had no problems, no health problems, until very, very recently, when the industry destroyed their environment, and then the West came in to save them with aid in the form of McDonald's and soft drinks, etc. And they have now become one of the world champions in obesity and diabetes. So if we want to look at the problems, the modern factors that cause cardiovascular disease, we should look at the modern lifestyle.
So let's take that a step further and also turn it on its head. As your closing advice or comment, if you single-handedly could revise the dietary guidelines as you will, what would your top tenets be?
Well, that's very, very interesting. It would look very much like a ketogenic diet, or at least low-carb diet, because I'm not that strict with people who come to me and I see their markers, body measurements, etc., and I see that they're perfectly healthy, then I have no reason to exclude fruit. Fruit may be the only category I allow, and then again, it's mostly low-carb fruit, apart from the classic carnivore food. But as I said, 93% of the population is metabolically unhealthy, so we first need to correct these factors. Therefore, the dietary guidelines should aim to reverse obesity, to reverse diabetes, to reverse autoimmune disease, cancer, dementia rates, which means lowering carb intake, cutting grains and legumes, and ultra-processed foods. That would be the number one priority. And we saw some 2 years ago the list drafted by this guy, I can't remember his name, the Compass list, which was a draft of the upcoming guidelines. And all the list was like 15 top were ultra processed high carb foods. And now it's being revised by the new guideline committee. Hopefully this will change in the right direction.
So, Dr. Pavlou, you've told us what not to eat. What must we eat?
Well, we should heavily rely on grass-fed red meat, grass-fed liver, which is a superfood, eggs coming from grass-fed chicken, healthy fats like grass-fed butter and ghee and tallow, and just small amounts of low-carb vegetable and fiber, as long as the individual does not have gastrointestinal problems. That's more or less what we need to eat. It's a bit restrictive, but yes, we got used to artificial tastes that have nothing to do with nature.
Yeah, absolutely. So this cardiovascular disease that you've described to us today seems to be a hallmark of the modern lifestyle. And if we went back to more like the Nguru used to eat before the Western population, Western experts came and interfered with the diet and made them all get cardiovascular disease, then we would be healthy. Just go back to eating how we were supposed to eat. Dr. Pavlou, yes. I just want to thank you so much for this thought-provoking discussion. I think you've given our audience so much to think about, especially when it comes to challenging conventional wisdom on cholesterol and statins and what drives cardiovascular disease, and conversely, what drives cardiovascular health. So thank you for sharing your encyclopedic knowledge of physiology and biochemistry and medicine and health with us. This has been so incredibly valuable.
Thank you for having me. I'd be happy to see people take up the course and watch the full lectures.
Absolutely. Yes, please, everybody.
I do see we've got a teaser. This was just a teaser.
Exactly. Dr. Pavlou has got 3 lectures in the upcoming Cardiovascular Health Training by Nutrition Network. So this really was a teaser. There is so much more information that you will find within the training. I do see we've got some questions coming in, but unfortunately we are out of time. I don't know why they only came in 2 minutes before the end. So I'm really sorry, Kieran and Leon. Wendy, thank you for your appreciative comments. I'm really sorry that we have to cut it short there, guys, but please do take the training. If you sign up now before the 27th, when it launches, you'll get 30% off. So this is a really good time to do it. If you have any concerns around fat and cholesterol and high-fat diets, then you really need to take this training, because it will explain the risks, the benefits, and all those things. Yeah, so please just take the training, deep dive into the science and the controversies and the practical strategies for prevention and treatment of cardiovascular disease and the promotion of cardiovascular health. It's designed for healthcare professionals, but honestly, it's open to anyone who's passionate about heart health. We all have a heart. So thank you all. Thank you to our audience. Thank you, Dr. Pavlou, and hopefully you'll join us for our live next week. Over and out.
Bye. Thank you.
Bye.